This is the third video in this series on hemostasis, and is part 2 of the discussion of normal physiology, specifically covering the topics of secondary hemostasis and fibrinolysis. The learning objectives of this video are first, to be able to describe the general features of the coagulation cascade. Second, to be able to list the antithrombotic control mechanisms which terminate clot propagation. Next, to describe the process of fibrinolysis. Then to describe the role of vitamin K in coagulation. And last, to diagram the interrelationship between platelet plug formation and the coagulation cascade. So here is the overview of hemostasis we saw in the first two videos of the series. In this video, I will essentially be discussing the right half of the screen, that is, everything from the coagulation cascade downstream. As with platelet activation, it's easy to get lost in the many specific details of the coagulation cascade. But first, let's begin with a few general principles. The coagulation cascade is a series of enzymatic conversions of inactive proenzymes, also known as zymogens, to activated enzymes. For example, and these are not the actual enzyme names, but just for illustration, imagine activated enzyme A comes along and induces a conformational change in proenzyme B, thus activating it. Then activated enzyme B might cleave something off of a proenzyme C, activating that, and maybe activated protein C then requires a cofactor of some kind in order to activate proenzyme D. And then comes along an inactivating enzyme which binds to enzyme D, preventing its action. Each step along the way gets multiplied in that each copy of enzyme A might activate 100 copies of enzyme B, and each copy of activated enzyme B might activate 100 copies of enzyme C, and each enzyme C might activate 100 copies of enzyme D. So from one molecule of activated enzyme A, we end up with 1 million molecules of activated enzyme D. This process is what is known as the cascade. Its initial trigger is normally vessel wall injury. It ends with the formation of fibrin strands and the termination of the cascade by various antithrombotic mechanisms. Remembering from before, it requires a careful balance between procoagulants and anticoagulants. Too much procoagulants and spontaneous clotting will occur, resulting in deep venous thromboses and pulmonary emboli. Too much anticoagulants and excessive bleeding and hemorrhaging will occur. Finally, the process of fibrinolysis eventually dissolves the clot. We saw this table briefly in the first video of this series. It demonstrates that most clotting factors in the cascade are designated with a Roman numeral, in addition to having one or more alternative names. The clotting factors are almost always known by the Roman numeral, with the exception of factors 1 through 4, which are always referred to by their names: fibrinogen or fibrin, prothrombin or thrombin, tissue factor, and of course calcium. A lowercase a after the Roman numeral designates the active form of the factor. Most activated factors are enzymes, with the major exceptions being 1a, commonly known as fibrin, 5a, and 8a. The traditional model of coagulation was first described in the 1960s as a means to explain lab findings when studying the process of coagulation in vitro, that is, in test tubes outside of the body. It was not necessarily intended originally to be a description of the processes actually occurring in the body. However, since it provided a relatively straightforward way to visualize a highly complex system and allowed one to understand abnormal results of coagulation tests, clinicians rapidly adopted it. It consists of parallel extrinsic and intrinsic pathways, so called based on whether or not the trigger was a compound that was extrinsic or intrinsic to the endothelium. The extrinsic pathway involves an integral membrane glycoprotein called tissue factor, along with clotting factors 7 and 10. The intrinsic pathway involves clotting factors 8, 9, 10, 11, and 12. The end result of both of these is the common pathway, which involves factor 10 along with thrombin and fibrin. Unfortunately, this traditional description is no longer believed to be the most accurate model of the physiology. it nonetheless is still widely taught in textbooks and university lectures. It's not that the traditional model is literally wrong, but rather that it is an oversimplification whose division into these distinct extrinsic and intrinsic pathways is artificial. In addition, it ignores the distinct phases of coagulation and has not typically included a thorough discussion of essential multi-component complexes. In the contemporary model of the coagulation cascade, there are 4 key multi-component complexes, each of which consists of an activated clotting factor enzyme, a cofactor, and the enzyme substrate. The first is called the extrinsic factor 10-ACE and is composed of activated factor 7, tissue factor, and inactivated factor 10. The intrinsic factor 10-ACE is composed of activated factor 9, activated factor 8, and inactivated factor 10. The prothrombinase complex is composed of activated factor 10, activated factor 5, and prothrombin. And last, the protein C complex is composed of thrombin, thrombomodulin, and inactivated protein C. These complexes are assembled on an anionic phospholipid surface for which calcium is required. The contemporary model's most important distinction from the traditional one is the central importance of tissue factor as a primary trigger for the whole cascade. Tissue factor is a membrane glycoprotein expressed in vascular adventitia. During the initiation phase, when it's exposed by vessel injury, it binds to factor 7, which is then activated. The tissue factor activated 7 complex, which combines with factor 10 on the plasma membrane, forms the first of the 4 key multi-component complexes, which is referred to as the extrinsic 10-ACE. The extrinsic 10-ACE activates factor 10, which then binds to activated factor 5 to form the prothrombinase complex, which in turn converts a small amount of prothrombin into thrombin. Although there is a small magnification effect, as each extrinsic 10-ACE can activate many copies of factor 10, and each activated factor 10 can activate many copies of thrombin, the amount of thrombin produced from the initiation phase is still insufficient to lead to significant generation of fibrin threads and thus a blood clot. For this, there is the amplification phase. The limited amount of thrombin produced so far activates more factor 5 as well as factor 8 and 11, while the 7A tissue factor complex as well as activated factor 11 is able to activate factor 9. Activated factor 9 binds to activated factor 8, which then forms the intrinsic factor 10-ACE, thus activating 10. The amplification effect at each step is such that the intrinsic 10-ACE ends up activating as much as 100 times the factor 10 that is activated by the extrinsic 10-ACE. Each activated factor 10 converts more prothrombin to thrombin, which in turn further accelerates the amplification process until there is a virtual explosion of thrombin generation. Von Willebrand factor, which we encountered in the last video on platelet activation, plays a key role in the amplification phase as it binds to inactive factor 8 that is circulating in the bloodstream, greatly increasing its half-life. In the final steps, thrombin converts fibrinogen, both that which is circulating and that which has been recently released by activated platelets, to fibrin. Soluble fibrin monomers spontaneously polymerize into relatively weak threads. Factor 13A, which is also activated by thrombin, then cross-links and strengthens the overlapping fibrin strands. The cross-linked fibrin, which forms a 3-dimensional mesh in which red blood cells and platelets become trapped, represents the final step in the conventional coagulation cascade. Referring back to the traditional model of coagulation for a moment, although it has some limitations, it will be helpful to know that the traditionally described extrinsic pathway, also known as the tissue factor pathway, incorporates these steps. The intrinsic pathway, also known as the contact activation pathway, incorporates these steps. And the so-called common pathway includes everything that's left. Now, there are several factors which have been historically included in the coagulation cascade in addition to what I've already mentioned, specifically the intrinsic pathway upstream of factor 11, which I've decided to not include in the diagram. Those are factor 12, kallikrein, and something called high molecular weight kininogen. While they have been identified in the lab as having a role in coagulation, I haven't listed them here because defects of these proteins do not result in a clinically apparent clotting disorder. For me, this raises doubt that these factors play any significant role in actual physiology. To prevent either spontaneous or runaway intravascular coagulation, there are three main antithrombotic control mechanisms. The first is antithrombin, formerly known as antithrombin 3, which is a serine protease inhibitor that inactivates thrombin, as well as factors 7, 9, 10, and 11. Binding to heparin, either endogenous or exogenous, greatly increases antithrombin's protease activity, though the physiologic role of heparin as an endogenous antithrombotic mechanism is unclear. The second antithrombotic control mechanism is the protein C pathway. In this, an integral membrane protein of the endothelium called thrombomodulin induces a conformational change in thrombin. The altered thrombin is incapable of activating platelets or converting fibrinogen to fibrin, but can now activate a proenzyme called protein C. Activated protein C, in association with its cofactor, protein S, inactivates factors 5 and 8, inhibiting the function of the prothrombinase and intrinsic factor 10ase complexes respectively. The last antithrombotic control mechanism is tissue factor pathway inhibitor. This is a single-chain polypeptide which can reversibly inhibit factor 10, as well as the 7A tissue factor complex. A small amount of tissue factor pathway inhibitor circulates in the bloodstream, while most is found attached to the microvascular endothelium. So what is the final end result of this incredibly complex series of reactions, starting with platelet adhesion and including platelet activation and secretion, platelet aggregation, the coagulation cascade, polymerization of fibrin, and last the antithrombotic control mechanisms? It's this. This is a colorized scanning electron micrograph of a thrombus or blood clot. Red blood cells are obvious. The irregular gray blobs are platelet aggregates. The green cell right in the middle is a white blood cell. And the hundreds of brown strands into which the cells are entangled are fibrin. For me, seeing a picture like this really emphasizes what an amazing process hemostasis is. As amazing as clot formation is, we don't necessarily want blood clots to hang around forever. Eventually, we need our blood vessels to become patent again. Clots are eventually removed by the body in the process of fibrinolysis. There are two major steps. First, plasminogen, which is a circulating proenzyme, is activated by conversion to plasmin by one of two similar enzymes, tissue-type plasminogen activator, also known as TPA, which is secreted from vascular cells and itself activated by thrombin, or urinary-type plasminogen activator, also known as urokinase or UPA, which is secreted from a variety of cell types. Plasmin then cleaves cross-linked fibrin, essentially severing the fibrin threads holding the blood clot together. This results in a variety of fragments known formally as fibrin degradation products, one of which is the D-dimer, which is composed of two D domains from adjacent fibrin monomers which are linked together. The D-dimer will be important when discussing certain pathologic conditions such as disseminated intravascular coagulation, as it can only be produced by plasmin cleaving fibrin, and thus its presence indicates intravascular clotting. In addition to fibrin, plasmin also cleaves fibrinogen and several other clotting factors. As with the main coagulation cascade, fibrinolysis has additional levels of regulation, specifically 3 inhibitors. The first is plasminogen activator inhibitor 1, which, as its name implies, inactivates TPA and UPA. Then there is alpha-2 antiplasmin, which inactivates plasmin. And finally, thrombin activatable fibrinolysis inhibitor, which actually acts on fibrin by cleaving the end C-terminal residues, which are important for the normal action of plasmin. In other words, it makes fibrin relatively resistant to degradation. The final topic to discuss is the important role that vitamin K plays in the coagulation cascade. In fact, the K of vitamin K is derived from Coagulationsvitamin, which is the German word for clotting vitamin. There are multiple types of naturally occurring vitamin K. Vitamin K1, also known as phyloquinone, is found in green vegetables with the highest concentration in spinach, kale, collard greens, and Brussels sprouts. In addition, there is vitamin K2, known as menaquinone, which is synthesized from vitamin K1 by normal gut bacteria. There are many similar forms of vitamin K2, which are named after the number of double bonds present on the side chain, which can become quite long. Vitamin K is fat-soluble and requires intact biliary and pancreatic function for effective absorption. The role of vitamin K is to act as a coenzyme in the post-translational modification of several clotting factors, specifically prothrombin, factors 7, 9, and 10, as well as protein C and protein S. It aids in the carboxylation of glutamic acid residues to form gamma-carboxyglutamyl residues, which allows the proteins to bind to calcium and thus allows them to be activated. Deficiency of vitamin K can lead to clinically significant bleeding. This is seen in a variety of conditions, most notably malabsorption syndromes. Vitamin K deficiency is also common in newborns, leading to a higher risk of bleeding in the first week of life. This is due to a combination of an immature liver that cannot effectively utilize vitamin K, relative lack of vitamin K in breast milk, and a sterile gut devoid of vitamin K synthesizing bacteria. Thus, parenteral vitamin K is typically administered at birth. So that concludes our grand overview of normal hemostasis. Let me return to this diagram once more. The very first reaction to vascular injury is vasoconstriction, followed by platelet activation, which is largely mediated by exposure of collagen. Platelet activation results in a change in platelet shape, platelet aggregation mediated largely by von Willebrand factor and fibrinogen, and results in the platelet plug. This phase of hemostasis is called primary hemostasis. The second phase of hemostasis is largely triggered by exposure of tissue factor during vascular injury, which triggers the coagulation cascade, the end result of which is thrombin's conversion of fibrinogen to fibrin. Fibrin polymerizes, generating fibrin strands, which are superimposed on the platelet plug and trap red blood cells to form a blood clot. This is secondary hemostasis. There are many critical points at which the platelets and coagulation cascade rely on one another. In addition, there are important antithrombotic control mechanisms which prevent both spontaneous intravascular coagulation as well as runaway coagulation in response to actual injury. And finally, the enzyme plasmin is responsible for cleavage of the fibrin strands and eventual clot degradation. That concludes part 2 of the normal physiology of hemostasis. If you found this video to be interesting and helpful, please remember to like it and share it with your colleagues and classmates. The next video in this series will discuss lab tests of hemostasis. This is the fourth video in this series on hemostasis, and today I'll be discussing tests of hemostasis. The learning objectives are first, to list the conventional tests of hemostasis and to describe how they are performed. These will include the platelet count, PT, and PTT. Next, to list the common etiologies of abnormal results of these tests. Then to describe how to approach an abnormality of PT or the PTT. And last, to interpret typical coagulation profiles. This video will start to introduce a few medications and common disorders of hemostasis, such as von Willebrand disease, hemophilia, and the antiphospholipid antibody syndrome. However, I won't be talking about these conditions in any depth here. Rather, they'll each be discussed in future videos in the series. Let me start by discussing the indications for hemostasis tests. To identify which patients presenting with acute bleeding have a correctable bleeding tendency, for example von Willebrand disease, hemophilia, and disseminated intravascular coagulation, just to name a couple. To identify which patients presenting with acute clots have a correctable clotting tendency, such as antiphospholipid antibody syndrome. To monitor response to anticoagulant medications, such as warfarin and heparin. To aid prognostication for patients with liver failure, for example, the PT test is used to predict mortality both in alcoholic hepatitis as part of a calculation called the discriminant function, and in cirrhosis as part of the MELD score. To screen for disseminated intravascular coagulation, commonly known as DIC, in patients with severe sepsis. And last, to screen for occult bleeding disorders prior to surgery or other invasive procedures. This last indication is controversial, and I'll talk more about it at the end of the video. I think about hemostasis tests in two categories. First are the common tests. These are the ones that I see ordered all the time in the hospital. They include the platelet count, PT and INR, the APTT, which is more commonly referred to as just PTT, fibrinogen, and D-dimer. Then there are the uncommon tests, which are ordered only in very specific situations. The only uncommon test I'll discuss more in this video is the mixing study, which is important in evaluating an increased PT and particularly PTT. However, there is also the thrombin time, which is a measure of the function of the common pathway. Although textbooks generally make a point of discussing this test, in over 10 years of internal medicine, I've never seen it ordered once or recommended by a hematologist in real life, and therefore won't be talking about it. Next is the activated whole blood clotting time, tests of anti-10A activity, and the Eckarin clotting times. These are all used exclusively to measure anticoagulation effect from specific medications and will be discussed in the anticoagulation video. Then there are various tests of antiphospholipid antibodies, qualitative platelet function, and heparin-induced thrombocytopenia. These three will be covered in future videos as well, at the same time as the relevant conditions are discussed. Not listed here is an archaic test called bleeding time, in which a standardized nick is made in a patient's skin, and the time it takes for it to stop bleeding is measured. Although mention of it still creeps into some review books, the test suffers from poor reproducibility and is essentially no longer performed. The first test to discuss in depth is the platelet count, which is both the most basic and also the most common of all hemostasis tests. Platelet counts are tested on machines called autoanalyzers as part of the complete blood count, which is a broader panel of hematology tests that also includes hemoglobin concentration and white blood cell count. The test must be performed on blood collected in an anticoagulated specimen vial, which is usually purple-topped, indicating that it contains EDTA. There are many etiologies of quantitative platelet abnormalities. A platelet count that is too low, a derangement known as thrombocytopenia, can be due to either decreased production of platelets, increased destruction, or hypersplenism, also known as sequestration. Decreased production is most commonly due to bone marrow disease, such as infiltration by cancer or systemic infection, or due to nutritional deficiencies such as B12 and folate deficiency. Decreased production is typically accompanied by decreases in the other cell lines of red and white blood cells as well. Now, increased destruction can be due to any of a very long list of medications along with alcohol. Also, autoimmune disease such as idiopathic thrombocytopenic purpura and DIC. A platelet count that is too high, usually called thrombocytosis, can be reactive in response to infection, surgery, particularly splenectomy, malignancy, or acute blood loss. Much less commonly, thrombocytosis is a consequence of a myeloproliferative disorder. Both thrombocytopenia and thrombocytosis will be the subjects of their own videos later in the series. One additional quantitative platelet disorder that should be discussed is pseudothrombocytopenia. This refers to a falsely low platelet count as a result of lab artifact. It's relatively common. There are two main etiologies. The more common of the two is incomplete mixing of blood collection tubes, which causes small clots to form, which then traps platelets and confuses the autoanalyzer. A less common etiology is EDTA-dependent agglutins. In this case, in order to get an accurate platelet count, a different anticoagulant must be used. Pseudothrombocytopenia can almost always be identified from a review of the peripheral blood smear, as in this case when we can see the extreme platelet clumping. The next test to discuss is called the prothrombin time, or more commonly just the PT. To measure the PT, whole blood is collected into a sealed, evacuated tube, which by convention is blue-topped, signifying that it contains citrate. The citrate binds calcium in the blood, which prevents the blood from coagulating. To maintain accuracy, a standard amount of blood must be collected into the tube such that the ratio of blood to citrated solution is also standardized. The whole blood is then centrifuged to separate the blood cells from everything else. The blood cells are then discarded, leaving a translucent yellowish fluid called plasma. Plasma is essentially the liquid portion of blood and predominantly contains electrolytes, albumin, immunoglobulins, glucose, and of course, clotting factors. To the plasma is added calcium and a substance called thromboplastin, which is a mixture of tissue factor and phospholipids. If we look back at the coagulation cascade from the video on normal hemostasis, we will be reminded that tissue factor is present here as the primary trigger for the tissue factor pathway, also known as the extrinsic pathway. Therefore, when added to plasma along with calcium, a fibrin clot will form. Macroscopically, this changes the translucency and color of the plasma and will transform the free-flowing liquid into a solidified gel-like substance. Any of those changes can be used by either a machine or a human being to determine when the clot has formed. The PT is defined as the time in seconds for this to happen. From the coagulation cascade diagram, you can see that this is a measure of the function of the tissue factor pathway. However, it is also a measure of the function of the common pathway, since deficiencies or abnormalities of thrombin, fibrinogen, factor V, or factor 13 will also lead to delayed clot formation. The normal range for the PT is about 11 to 14 seconds, but this has high variation due primarily to differences in the manufacturer's thromboplastin, but also due to differences in incubation time, differences in the storage conditions of the samples, and differences in the method of endpoint detection. This is actually a big problem, particularly for patients on anticoagulant medications affecting the tissue factor pathway, such as a medication called warfarin. For example, the degree of anticoagulation a patient on warfarin might be experiencing could be labeled appropriate by one lab, too much by another, and too little by a third. This inconsistency made it very difficult to publish standardized guidelines about how these drugs should be used and monitored, and it made it impossible for a patient on warfarin to have their coagulation profile monitored by more than one lab. However, in the early 1980s, to account for this variation, a derived value called the International Normalized Ratio, or INR, was developed. The INR is calculated as the patient's PT divided by a controlled PT raised to the power of something called the ISI, which stands for the International Sensitivity Index. The ISI is specific for each lot of thromboplastin reagent. The ISI of each lot is provided by the commercial vendors of thromboplastin, but should be independently confirmed by the clinical laboratory. This didn't completely eliminate the problem of standardization, but it greatly reduced it. A normal INR for someone not on anticoagulation is 0.8 to 1.2. So what are the etiologies of an abnormal INR? Well, first, is there such a thing as an INR that is below normal? There is, but an INR significantly below normal is very uncommon, has been poorly characterized, and is of unclear clinical significance. In other words, unless you're a hematologist, you'll probably never need to worry about it. However, there are many causes of an elevated INR. They can be subdivided into some anticoagulants, those associated with a decreased synthesis of clotting factors, which can be from chronic liver disease or vitamin K deficiency, and those associated with an increased consumption of clotting factors such as sepsis and DIC. The next test to discuss is the activated partial thromboplastin time, frequently called the PTT. I don't actually know why everyone always drops the A when saying it aloud, but they do. This test is nearly identical to the PT, with one important difference. Once the plasma has been separated from the cells, instead of calcium and thromboplastin, calcium and something called partial thromboplastin is added. This partial thromboplastin consists of phospholipids without tissue factor. And without tissue factor present, an activating agent must be added in its place, which is often silica or diatomaceous earth. As with the PTT is the time in seconds it takes for the fibrin clot to form. The PTT measures the function of the contact activation and common pathways. The normal range for the PTT is about 25 to 40 seconds, but it has substantial variation across different reagents and testing systems. Unlike PT and the INR, there is no equivalent standardization of the PTT, and therefore each lab and hospital should establish their own normal range and adjust anticoagulation protocols accordingly. Having been the one responsible for coordinating such an adjustment once at a hospital, I can attest to the fact that the process is haphazard and inexact, which is why I personally have very limited confidence in the safety of infusions of unfractionated heparin, which rely on the PTT test for titration. This will be discussed more in the video on anticoagulant medications. There are a fair number of causes of an elevated PTT. They include anticoagulants again, a genetic defect in von Willebrand factor, predictably called von Willebrand disease, hemophilia, antiphospholipid antibodies, sepsis, and DIC. The next test, fibrinogen, is not ordered nearly as frequently as the PT and PTT, but it's still not rare. To remind you, fibrinogen is a glycoprotein critical for both the formation of the platelet plug, as well as serving as a precursor for fibrin, which is the penultimate step of the whole coagulation cascade. Fibrinogen is synthesized in the liver, and its normal range is around 200 to 400 milligrams per deciliter. Most abnormalities of fibrinogen are quantitative. However, both thrombophilic and hemorrhagic versions of congenital dysfibrinogenemia also exist, in which measured levels of fibrinogen are normal, but these are very rare. Quantitative abnormalities of fibrinogen can either be high or low. High fibrinogen can be seen as part of a general increase in so-called acute phase reactants, which are a collection of compounds in the blood whose levels increase in response to nonspecific tissue injury, inflammation, or infection. Other acute phase reactants include ferritin, C-reactive protein, C3, and C4. High fibrinogen is also frequently observed in normal pregnancy. Low fibrinogen is predominantly seen in two conditions, liver failure and DIC. The last of the common hemostasis tests is the D-dimer. As mentioned in the last hemostasis video, the D-dimer is the most clinically relevant of the numerous types of fibrin degradation products. It consists of two D domains from adjacent fibrin monomers. Thus, the presence of D-dimer requires recent intravascular coagulation. The normal range is less than 0.5 milligrams per deciliter, which is sometimes expressed as less than 500 micrograms per deciliter. There are many causes of an elevated D-dimer. The most clinically relevant include venous thromboembolism, such as a PE, arterial clot anywhere, DIC, severe sepsis, malignancy, recent surgery or trauma, liver disease, and once again, normal pregnancy. So those are the 5 main coagulation tests: platelets, PT or INR, PTT, fibrinogen, and D-dimer. When one considers all 5 together, the group is considered a coagulation profile and often can be collectively ordered as something called the DIC panel. Let's review what typical coagulation profiles look like for some common diseases. In advanced liver disease, platelets will be low due to hypersplenism and splenic sequestration. The INR will be high due to impaired production of clotting factors, and the PTT can also be high or is occasionally normal. Fibrinogen will be low, and D-dimer will either be normal or elevated. In DIC, platelets are low. The INR and PTT are either normal or elevated. Fibrinogen is normal or low, and D-dimer is usually elevated. Although not included in this panel, the other key finding in DIC is a so-called microangiopathic hemolytic anemia, identifiable by encountering red blood cell fragments called schistocytes on a routine blood smear. In von Willebrand disease, platelets are usually normal but occasionally mildly decreased. INR is normal, PTT is normal or elevated, and both fibrinogen and D-dimer are normal. In both hemophilia and antiphospholipid antibody syndrome, often the only abnormality is an elevated PTT. And in pregnancy, platelets can be either normal or low. The INR and PTT are normal, and fibrinogen and D-dimer are elevated. The condition in which an otherwise normal pregnancy is accompanied by mild thrombocytopenia is called gestational thrombocytopenia, which is important to distinguish from a serious complication of pregnancy called HELP syndrome. The HELP is not like the word help, as I can get some help, but rather an acronym standing for hemolysis, elevated liver enzymes, and low platelets, which are the 3 main features of the disorder. All of the diseases in this chart are going to be discussed in more detail later in the series. Now, among the tests that I designated at the beginning of the video as uncommon, there is one which merits discussion here. That is the mixing study. Clotting tests can be abnormal due to either a clotting factor deficiency or due to the presence of an inhibitor of normal factor activity, usually an antibody. A mixing study differentiates between these 2 possibilities, and it relies on the observation that clotting tests generally only require factors to have 50% or sometimes even less of their normal activity in order for the test to be normal. So here's how a mixing study works. Some volume of the patient's plasma is literally mixed together in a 1-to-1 ratio of pooled plasma from normal individuals. Then the initially abnormal clotting tests are rechecked. If the abnormal clotting test normalizes, the patient must have a factor deficiency because whichever factor was deficient in the patient's plasma has been supplemented by the normal level of that factor in the normal plasma. But if the clotting test does not normalize, the patient must have a factor inhibitor because when factor inhibitors are present, their concentration is usually high enough to inhibit the additional factors added to the mix from the normal plasma. The one caveat to this relatively simple test is that some inhibitors require time to inhibit the clotting factors that have been added from the normal plasma. Therefore, if the clotting times in the mixture are normalized when checked initially, the test should be repeated and the mixed plasma allowed to incubate at 37 degrees for several hours before checking once more. The lab should then report both the results of the mixing study when performed immediately and when performed after incubation. So now let's put all this information together into a helpful, practical algorithm for investigating abnormal coagulation tests, that is, focusing just on the PT and PTT. There are many algorithms out there on the internet, and they actually vary quite a bit. But this is the one that makes the most sense to me and most conforms to my own clinical experience. Importantly, this algorithm assumes the patient is on no anticoagulant medications and is not critically ill. If either the PT alone or both the PT and PTT are prolonged, then give the patient vitamin K. If the test or tests correct, you have your diagnosis, vitamin K deficiency. If there is not correction, next consider whether the patient has severe liver disease. If they do, the prolonged clotting times are almost certainly due to that liver disease. This isn't necessarily true 100% of the time, but if a patient has both severe liver disease and another completely independent clotting disorder, it will be very challenging to diagnose the latter, and if that's a consideration, you should consult a hematologist. If the patient either has no liver disease, or if the liver disease is mild enough that a secondary clotting disorder seems unlikely, then perform a mixing study. And if between the PT and PTT only the PTT is prolonged, then go right to the mixing study. From the mixing study, if the prolonged clotting corrects, next check the patient for von Willebrand disease and measure specific factor activity levels. On the other hand, if there is no correction, next check for antiphospholipid antibodies and specific factor inhibitors. So I'm almost at the end, but there are just two very quick practical topics that also need to be mentioned. First is the interpretation of coagulation tests in patients with liver disease. It's commonly believed that liver patients with abnormal coagulation panels have an increased risk of bleeding. On the wards, I often hear the term auto-anticoagulated, particularly in the context of the decision to not place a patient with cirrhosis on DVT prophylaxis. However, the reality is much more complicated. There are reduced levels of most procoagulant factors, that's true, but also most anticoagulant factors as well. There are actually increased levels of factor VIII, and while there are frequently reduced platelet counts, which predispose to bleeding, there are also increased levels of von Willebrand factor and decreased levels of ADAMTS13, which may predispose to clotting. Therefore, liver patients with markedly abnormal coagulation tests may actually still be in hemostatic balance, but it's a much more precipitous balance. In addition to decisions about DVT prophylaxis, the other scenario in which this comes up is when a surgeon or other proceduralist requires a liver patient to receive transfusions of FFP in order to drive the INR down below some arbitrary value prior to performing a procedure. In the absence of other evidence that the patient is at high risk of bleeding, this is probably not justified, particularly if such a transfusion will either risk volume overload or will delay a critical, time-sensitive intervention. Finally, I will end with a few words about the use of coagulation panels to screen for bleeding disorders in asymptomatic patients, particularly those with no family history. I started off this video with a list of common indications for coagulation tests, and this is one of them, but it probably should not be. So first, it's very common for the INR and PTT to be checked before routine surgeries and other procedures. However, the INR and PTT have low sensitivity and specificity for bleeding disorders. The rate of clinically significant but occult bleeding disorders in otherwise healthy people is quite low. And personal or family history of excessive bleeding is much more predictive of perioperative bleeding than coagulation tests. Therefore, many experts recommend an emphasis on personal and family bleeding history when predicting operative bleeding risk, and explicitly recommend against the use of coagulation tests for this purpose. In my own practice, I will still frequently order preoperative INRs and PTTs in otherwise healthy people, but that's only because those performing the procedures usually insist on it. This is not necessarily a battle worth fighting with your hospital colleagues. So that concludes this video on the test of hemostasis. The next 3 videos will discuss medications which alter hemostatic balance, specifically antiplatelet drugs, anticoagulants and fibrinolytic meds, and the less commonly used pro-clotting meds.